So good evening, doctors.
Yeah, good evening.
Ashi madam has also joined, I guess, ma'am.
He's joined. Yeah.
Yeah, ma'am. Good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for the day is PCOS, insulin resistance, and gut dysbiosis. So I would like to welcome the participants, and I request them to post their queries in the comment box so that we can have a short Q&A session at the end of the presentation. And I would like to Chitra, can you disable so that I can share the screen of the speaker?
Yes, sir, you can share now.
Yes. Yeah. Today we have our chairperson, Dr. Abba Sharma, ma'am. Madam is a senior consultant and she's working for the past 30 years. And we are also like to invite our speaker for today's webinar, Dr. Vandana Gupta, ma'am. Madam has completed MBBS and MS, and she's a gold medalist in her MS. And Madam is also a senior consultant in obstetrics and gynecology at Max Hospital, Delhi, RK Hospital, and Apex City Hospital, Delhi. Madam is also the vice president of Delhi Gynecology Forum East, and Dr. Madam has received various awards like Dr. G.P. Rawat Memorial Gold Medal for Obstetrics and Gynecology, and Mrs. Wazir Singh Chowke Silver Medal for Obstetrics and Gynecology, and Abdul Kalam Appreciation Award and DGF 2016, and Dr. Ray Appreciation Award DGF 2015. And I would also like to welcome our moderator for the today's session, Dr. Ashi Sahai, ma'am. Madam has also completed her MBBS and MS from SNMC Agra 1982, and Madam is currently the director of Sahai's Mother and Child Clinic, New Delhi, and she is also the visiting consultant at Jeevan Anmol Hospital and Max and Apex Hospital, New Delhi, Kailash Hospital, and New Delhi. With this introduction, I welcome you all, ma'am. Ma'am, before going to the section, we would like to play a 1-minute video on our Shield Connect webpage launch, ma'am. So Chitra will be playing a 1-minute video. So thank you, ma'am. The Shield Connect is a new initiative of our Shield Healthcare, ma'am, and it has various blogs and written by various doctors. And I request you to give us some blogs which you need to be posted in our web page, ma'am. And we also have these are the all our webinars are conducted through our Shield Connect web page only, ma'am. You can see the details of upcoming webinars and the past webinars. And we have also a separate page for PCOS awareness, where you can see various doctors speaking about our PCOS in various regional languages, and it will be like an awareness video. And yeah, these are the videos, ma'am. We can see videos by various doctors in various languages. We have a separate page for our leaders, so you can see our leaders who are supporting our web page. So we have more than 220 doctors around the country who are supporting, and we have a separate page for the speakers. So you can just see your web page here, ma'am. So what and all the webinars you are giving and all your details will be uploaded in our web page, ma'am. So thank you, ma'am, and I would like to hand over the session to you, ma'am.
Thank you. So I should start my
Yes, ma'am.
screen sharing.
Ma'am.
Yeah. So today we'll be talking about PCOS and gut dysbiosis and infertility management. So the introduction is that polycystic ovarian syndrome is very common. It affects nearly 5 to 20%, maybe more, because we are facing a lot of stress in life. Heterogeneous conditions may present with reproductive, endocrine, and metabolic and psychosocial symptoms. It remains underdiagnosed with significant delay in diagnosis because of various overlaps. It's a complex disorder impacting quality of life, requires timely diagnosis, screening for complications, and management strategies. So, epidemiology is one of the most common endocrine disorders affecting women of reproductive age, seen in 8 to 11% per reproductive age group women, and it's mostly an ovulatory infertility, and nearly 70 to 80% an ovulatory infertility is seen in PCOS. Indians have amongst the highest prevalence rates in the world, that is 41% in the reproductive age. So, pathophysiology, we know it is involving insulin resistance, abnormal gonadotropin levels. Insulin resistance leads to hyperinsulinemia, leads to ovulatory dysfunction. All of them together lead to ovulatory dysfunction associated with the hyperandrogenism because of increased adrenal androgens, decreased SHBG levels. Also, the androgens are coming not only from adrenals but from the ovaries itself. There is a follicular arrest and giving a polycystic ovarian morphology. There could be uterus could be suffering with endometrial hyperplasia. There could be anovulation and amenorrhea. Because of hyperandrogenism, we have skin affectations like acne, hirsutism, acanthosis, nigricans. Diagnosis, we are following, these are the various guidelines, but we are following the Rotterdam criteria, in which any of the two of the three criteria could be taken. This is oligo or chronic anovulation, clinical and or biochemical hyperandrogenism, and polycystic ovarian morphology. And other two are nearly the same. They have a little bit of difference in their opinion. So the spectrum from PCOS from childhood to postmenopause. In a polycystic ovarian factor, the predisposing factors are genetic, in utero programming as well. And in childhood, could be increased AMH levels. In puberty, we can see a premature adrenarche, hyperandrogenism, increased GnRH pulse frequency, increased AMH, increased ovarian volume, hyperinsulinemia. And in reproductive years, we face irregular cycles, again, hyperandrogenism, subfertility and infertility, increased AMH, antral follicle count, ovarian volume, glucose intolerance, and insulin resistance. They go hand in hand. In postmenopausal years, the metabolic disorders will become more common, increased prevalence of hypertension, increased triglycerides, and glucose intolerance and insulin resistance. So these are the different phenotypes of PCOS across the lifespan has been seen. So there are different phenotypes depending on what is the presentation. In phenotype A, all the three characters would be present, that is hyperandrogenism and hirsutism, ovulatory dysfunction, and polycystic ovarian morphology. When polycystic ovarian morphology is absent, only the above two are present, then it's phenotype B. In phenotype C, ovulatory dysfunction is absent, but we have hyperandrogenism and polycystic ovarian morphology. And in phenotype D, we have absent hyperandrogenism. And absent hyperandrogenism, this phenotype fares well. Presence of hyperandrogenism is really detrimental for ovulation. So, what are the causes? Could be genetics and lifestyle, hormonal changes. Obesity exacerbates hormonal changes, that is, increased androgens leading to hirsutism and acne, and increased insulin leading to diabetes and metabolic syndrome, increased cardiovascular risk. And these two lead to ovarian follicle and ovulation, increased estrogen, menstrual disturbances, subfertility, and also endometrial hyperplasia. These could lead to psychosocial issues, body image, self-esteem, depression, and anxiety. So the epidemiological link is PCOD increases the risk of GDM by more than 200%, but PCOD increases the risk of type 2 diabetes mellitus by 1600%. So that is where the link comes for elderly. And insulin resistance is present in 65 to 80% of PCOD cases, and 60% of GDM patients might develop type 2 diabetes mellitus later in life. So there is a big link. The clinical feature are gynecological, veno irregular menses, and infertility. Metabolic would be insulin resistance, obesity, increased chances of type 2 diabetes mellitus, acanthosis nigricans, and androgenic features would be alopecia, hirsutism, and acne. The factors that predict live birth in PCOS would be younger age, lower BMI, shorter duration of infertility, less severe oligomenorrhea, and lower androgen levels. This is very important because higher androgen levels give rise to poor ovum quality. The PCOS and fertility, most women with PCOS achieve their desired family size. For some of these women, medical support may be needed. See, 30% patients will come with no problems. They become pregnant without any problem. And the 70% patients may experience problems getting pregnant. A healthy, active lifestyle improves their chances of becoming pregnant. And women with PCOS commonly have problems becoming pregnant because of anovulation. So the first line treatment, we always say improvement in lifestyle, that is weight loss and diet. In obese patients, weight loss, changes in diet and physical activity is recommended. Weight loss decreases serum insulin androgen levels, reduces the risk of glucose intolerance and type 2 diabetes mellitus. Pharmacological interventions would be in the presence of insulin resistance or glucose intolerance or dyslipidemia that persists after lifestyle modification. Then we introduce our drugs at that stage. So these are the various guidelines, practicing guidelines, which have been given international evidence-based guidelines for assessment of and management of polycystic ovarian syndrome. These are the 5 guidelines. They could be screening, diagnostic assessment, risk assessment, life stage, and adolescence. In type 2 guidelines, prevalence, screening, diagnostic assessment, management, and emotional well-being. And three guidelines, they say only lifestyle, and the fourth is pharmacological treatment in PCOS for non-fertility indications. And again, 5 is screening, diagnostic assessment, and management of infertility. So the lifestyle interventions in PCOS, with increasing weight, there is a reduced ART success, worsened psychological functions, worsened cardiovascular disease and type 2 diabetes mellitus, increased androgen activity, increased insulin resistance, ovulatory dysfunction, infertility, oocyte, and embryo. Over here, it is being depicted in this that BMI less than 25 will have a lesser percentage of PCOS, and as the BMI increases, the percentage with PCOS increases. So significantly, there is a linear trend in PCOS prevalence. 9% increased risk of developing PCOS for every 1 unit increase in BMI. That is very significant. So, decreasing BMI would definitely help. Obesity affects spontaneous pregnancy chances in some fertile and ovulatory women. BMI greater than 29 was associated with reduced success of ongoing pregnancy and 4% lower pregnancy rate per kilogram meter squared of BMI. So, continuation getting pregnant is difficult with increased BMI, and once the lady becomes pregnant, continuation of pregnancy is also difficult. So 9% chances with increasing BMI, she has a lower rate of becoming pregnant, and 4% lower pregnancy rate lower continuation of pregnancy rate per kilogram of BMI. Lifestyle intervention. Healthy lifestyle for excess weight gain prevention is important. Overweight or obese, we aim for 5 loss over a period of 6 months. We monitor and support with achievable goals, assess weight respectively in at least 6 to 12 monthly intervals. So these are the various clinical guidelines depending on what we have taken. These are clinical recommendations, these are evidence based recommendations, these are clinical practice guidelines, and this was what I found. They all are nearly the same. This was very important, that smart, that is specific, measurable, achievable, realistic, and timely goal setting and self monitoring can enable achievement of realistic lifestyle goals. All these recommendations say that healthy lifestyle behaviors would definitely improve. Again, these are clinical recommendations and clinical practice guidelines. Tailoring changes of food preferences, allowing for a flexible and individual approach to reducing energy intake and avoiding unduly restrictive and nutritionally unbalanced diets are important as per general population recommendations. So it has been nearly the same over the various recommendations. And these are the recommendations for exercise. They are also nearly the same. These are clinical guidelines that we say in adults from 18 to 64 years, a minimum of 150 minutes per week of moderate intensity physical activity or 75 minutes per week, that is half, of vigorous intensity or an equivalent combination of both, including muscle strengthening activities on 2 non-consecutive days of a week. In adolescent, at least 60 minutes of moderate to vigorous intensity physical activity per day, including those that strengthen muscles and bone at least 3 times a week in adolescent. Activity be performed in at least 10 minutes bout or around 1,000 steps, aiming to achieve at least 30 minutes daily on most of the days. So these are nearly the same guidelines which are being given. The role of bariatric surgery is very doubtful. Bariatric surgery should be considered an experimental therapy in women with PCOS for the purpose of having a healthy baby. Here we are looking for healthy baby, not for metabolic disorders. With the risk to benefit ratios currently too uncertain to advocate this as a fertility therapy. If bariatric surgery is to be prescribed, the following should be considered: the comparative cost, the need for a structured weight management program involving diet, physical activity, and interventions to improve psychological, musculoskeletal, and cardiovascular health to continue post operatively. Perinatal risks, such as small for gestational age, premature delivery, and possibly increased infant mortality, and because of malabsorption syndrome, which might accompany bariatric surgery. Potential benefits such as reduced incidence of large for gestational age fetus and gestational diabetes, recommendations for pregnancy avoidance during the periods of rapid weight loss and for at least 12 months after bariatric surgery with appropriate contraception. If pregnancy occurs, monitoring pre and post operative nutritional deficiencies and monitoring of fetal growth during pregnancy becomes very, very important. So management of infertility, that is assessment and treatment of infertility. First line non-pharmacological management is lifestyle intervention, that is diet and exercise. Then the first line pharmacological management would be letrozole, which has become the first line therapy in a polycystic ovarian disease because we are looking at a monofollicular development. Clomiphene citrate is an age old drug which has been used. Clomiphene citrate plus metformin can be used. Only metformin has also been tried. And then we go to gonadotropins. The second line pharmacological management could be gonadotropins and laparoscopic ovarian surgery. Third line management could be other appropriate interventions, including IVF. So letrozole, these are again evidence-based recommendations that letrozole should be considered first-line pharmacological treatment for ovulation induction in women with PCOS and anovulatory infertility, provided there is no other infertility factors to improve ovulation, pregnancy, and live birth. So, how we give letrozole, we all are very used to giving, starting from day 2 for 5 days, and ultrasound is done on day 11 and day 13 to look for ovulation. Extended protocol also can be used for another 5 more days. And there is another letrozole step up protocol, which makes the dose double. On day 1, we are using 1 tablet of 2.5, day 2, we are using 2 tablets, and 3 tablets, 4 tablets, and 5 tablets successively. So, in clomiphene citrate, we have been using for over the years 50 milligrams per day, starting from day 2. And again, the ultrasound is to be done on day 11 and 13. 50 milligrams per day, no ovulation. Then we proceed to 100 milligrams, no ovulation. We proceed to 150 milligrams. And either of the doses gives us ovulation. We continue with the same dose for 2 to 3 cycles. And if there could be a suboptimal endometrium, we know clomiphene citrate gives rise to poor endometrium, which is less than 7 or there is no pregnancy, or there is hypogonadotropic hypogonadism, then we proceed to injectable gonadotropins. So failure with this is called CC resistant. When the patient does not ovulate, there is failure to ovulate even with highest dose of clomiphene citrate. The clomiphene citrate and metformin, these are again evidence based recommendations. Clomiphene citrate can be used alone in women with PCOS. And if metformin is being used for ovulation induction in women with PCOS who are obese, that is BMI greater than 30, with anovulatory fertility and no other infertility factors, CC can be added to improve ovulation, pregnancy, and live birth rate. Others are nearly the same. So these are clinical practice lines. These are where metformin is prescribed. We need to see there are adverse effects associated with metformin, including GI side effects that are generally dose dependent and self-limiting, need to be subject to individualized discussion. Starting at a low dose, 500 milligrams increments at 1 to 2 weekly, and extended release preparations may minimize the side effects. Metformin use appears safe long term based on use in other populations. However, ongoing requirement need to be considered and may be associated with low vitamin B12 levels. Use is generally off label, and health professionals need to inform the woman and discuss the evidence, possible concerns, and side effects. So, use of gonadotropins, these are evidence based recommendations. Gonadotropins could be used as second line pharmacological agents in women with PCOS who have failed with first line oral ovulation induction therapy and are anovulatory and infertile with no other infertility. See, they could be used, they can be used wherever they are available. We have to see about the cost. Either gonadotropins or laparoscopic ovarian surgery could be used in women with PCOS with anovulatory infertility, clomiphene citrate resistant cases, and no other infertility factors following counseling on benefits and risk of each therapy. So, the gonadotropin therapy is suitable for improving infertility in women with PCOS in specialist care with close monitoring. Gonadotropin therapy provides better per cycle and cumulative pregnancy and live birth rates compared with the use of oral anti-estrogens or no therapy in anovulatory women with PCOS, and there is no evidence of teratogenicity. It is important to note that gonadotropin therapy requires daily injections and the need for intensive monitoring with ultrasound, with the risk of multiple pregnancy and increased cost of medication compared with oral agents. So, laparoscopic ovarian surgery, the evidence based recommendations say that laparoscopic ovarian surgery should be the second line therapy for women with PCOS who are clomiphene citrate resistant, that is, they are not ovulating with CC, highest dose of CC with anovulatory fertility, and no other infertility factors. So it could be laparoscopic surgery could be second line therapy. Laparoscopic or could be potentially offered as a first line treatment if laparoscopy is indicated for any other reason in a woman with PCOS with anovulatory fertility and no other infertility factors. Risk should be explained, And the risk would be that is comparative cost is higher, expertise is required. Intraoperative and postoperative risks are higher in women who are overweight and obese. There may be a small associated risk of lower ovarian reserve or loss of ovarian function. Periadnexal adhesions formation may be an associated risk. So now we come to how to improve the polycystic ovarian syndrome by using oral agent, that is a role of inositols in PCOS. Inositols are insulin signaling agents. The insulin receptor resides in the cell membrane when its beta subunit is phosphorylated by insulin, and it forms the insulin receptor substrates. This is P13 docks to the insulin receptor substrates, which then leads to phosphorylation of phosphatidyl inositol, eventuating in insulin action. Myoinositol increasing insulin sensitivity by making more phosphatidyl inositol available. So MI and DCI deficiency in PCOS has been documented and seen in over many cases. So this has been both MI and DCI levels are very low in PCOS patients compared to normal subjects. In plasma, the levels of in PCOS subjects, the levels are lower, and in normal subjects, the levels are higher of inositols. And urinary excretion of inositols is more in PCOS patients than in normal patients. So there has been a meta-analysis of 9 RCTs involving 247 cases and 249 controls. Significant decrease in fasting insulin levels have been seen. Significant decrease in HOMA index has been seen. A trend of reduction in testosterone is seen by MI. Significant increase in serum SHBG was observed after a 24 weeks treatment. The trial sequential analysis of insulin meta-analysis illustrates a firm evidence of myo-inositol use, beneficial effects of myo-inositol in improving the metabolic profile of PCOS women, concomitantly reducing hyperandrogenism. So this has been proven. So we know myo-inositols reduce fasting insulin levels in polycystic. It reduces HOMA index, it reduces testosterone, and it reduces androstenedione. It favors live birth rate in PCOS. There has been a shift towards the right, but there has been an increase in live birth rate, which has been shown by different authors. And anisotol pre-treatment to IVF also improves the live birth rate. And anisotol favors live birth rate in ovulation induction also. Over here also, after using ovulation induction agent along with use of myoinositol, the live birth rate is increased. And anisitols favor clinical pregnancy versus metformin. So again, here there is a shift to right, and these have got a better live birth rate. And analysis of clinical pregnancy comparison of 2-minoxidil versus antioxidants as pre-treatment to IVF in women with PCOS outcome has been seen in different clinical pregnancy outcomes. So it has been anisotol favors the clinical pregnancy and can be used as a pre-treatment. It betters the adverse event profile. The adverse events are reduced, and comparison of 5-minoxidil versus ovulation induction agents in women with PCOS undergoing ovulation induction. So anisotol for subfertile women, and this review says the adverse event profile is reduced. So the peculiarities they have in IVF, the PCOS women undergoing IVFs have some peculiarities. The goal is a successful pregnancy and having a safety profile. A meta-analysis of outcomes of conventional IVF in women with PCOS. These are weighted means they have been seen, and these are the chances of cancellations are reduced. Number of ovum picked is more. Number of oocyte fertilized is more, and the chances of live birth rate. These are the odd ratios which are favoring, and these are the chances of miscarriage per started cycle again is being balanced. So cumulative live birth rates after IVF in patients with polycystic ovaries. This has been a retrospective cohort study. The conclusions are hyperandrogenic PCOS phenotype confers significantly lower live birth rate compared with their non-normoandrogenic counterparts. These findings may imply the need for adapted counseling and tailored approaches when treating patients of PCOS with hyperandrogenism, which require an ART. So these are the cumulative live birth rates after IVF in patients with PCOS, and the phenotype matters. So we have seen in clinical live birth rate in A, it is 25 point, because they all have, these two have hyperandrogenism associated, and no hyperandrogenism in D. So we see 48%, and in women with have only polycystic ovarian morphology, we have 53.3%. The more severe the PCS phenotype, the lower the probability of live birth rate. So the influence of metabolic syndrome on female fertility and in vitro fertilization. It has been seen that women with polycystic ovarian syndrome with metabolic syndrome have a negative impact for the female fecundity, and this suggests an adverse effect on in vitro fertilization cycle stimulation characteristics and clinical outcome. Obviously, a patient who's carrying a genetic imprint for metabolic syndrome will definitely be poorly placed. So, in vitro maturation, this is a term which has been seen in clinical, given in clinical recommendations in clinical practice lines. Recommendations would be in units with sufficient expertise, IVM could be offered to achieve pregnancy and live birth rates approaching those of standard IVF plus ICSI treatment without the risk of OHSS for women with PCOS, where an embryo is generated, then vitrified and thawed and transferred in a subsequent cycle. So ovarian stimulation for IVF in PCOS, the evidence-based recommendations say a gonadotropin releasing hormone antagonist protocol is preferred in PCOS undergoing IVF ICSI, or over a gonadotropin release hormone agonist or long protocol to reduce the duration of stimulation, total gonadotropin dose used, and incidence of OHSS. So the choice of FSH could be any urinary, the clinical recommendation, urinary or recombinant FSH can be used in women with PCOS undergoing controlled ovarian hyperstimulation with insufficient evidence to recommend specific follicle stimulating hormone. Exogenous luteinizing hormone is not required. This is clinical recommendation. So adjunct, we can use metformin. The evidence-based recommendation, they say adjunct metformin therapy could be used before and or during follicle stimulating ovarian stimulation in women with PCOS undergoing IVF with a GnRH agonist protocol to improve the clinical pregnancy rate and reduce the risk of OHSS. And ovarian stimulation again is the same. These are the clinical practice guidelines, and we can have to see, we all have to see that in the when the ovarian stimulation is being done, then in that IVF cycle, all when the ovum pickup is being done, all the embryos are frozen and they are transferred in the next cycle. So the adjunct as metformin, we are going back. So individualization of controlled ovarian stimulation in IVF using ovarian reserve markers from theory to practice. So whenever the AMH is high, there would be an expected high response, and GnRH antagonist protocol plus minimal FSH stimulation has main objective would be to reduce the OHSS. When the AMH is in the middle of the parameters, then we expect a normal response and maximum success rate, and we use a standard treatment. When the AMH is low, it could be an expected poor response. Main objective is to minimize treatment burden. GnRH antagonist protocol plus maximal FSH stimulation would be recommended. So does freeze-all increases the chances of live pregnancy in high responders? Yes, definitely. Role of myoinositols, we come to role of myoinositols in gut dysbiosis. So myoinositols are playing a dual role in a patient with PCOS. They are taking care of phosphorylation and insulin resistance, and they also have a role to play in gut dysbiosis. So the pathophysiology is dogma theory, that is dysbiosis of gut microbiota. Diets rich in saturated fatty acids and sugars, they lead to growth of bad gram-negative bacteria in the gut, reduce bifidobacterium and lactobacillus. Cell wall gram-negative bacteria has an immunostimulant lipopolysaccharide. And like this, LPS enters the systemic circulation, innate immune system activation with the release of cytokines. This LPS is causing release of cytokines, and this thus leads to chronic low-grade inflammation in PCOS. So the healthy gut, we are seeing a healthy gut versus a leaky gut. A healthy gut, nothing can enter. So these are gut microorganism, food particles like gluten, lecithin, lectin, and sugars and drugs. But whenever there is a leaky gut, everything can enter the body and leads to inflammation, translocation of intestinal contents, food sensitivities, immune response, leading to autoimmunity. So, inflammatory markers in PCOS, circulating inflammatory markers in PCOS, there has been a systemic review, and they say that gut permeability is increased, metabolic endotoxemia is seen. That is, we see increased CRP, TNF alpha, and IL-6. These are increase in cytokines, leading to chronic inflammation. TNF alpha causes phosphorylation of insulin receptor protein, leading to insulin resistance. In lean PCOS, the leaky gut causes increases TNF alpha and IL-6. TNF alpha and IL-6 have been linked to insulin resistance. Endotoxin LPS in the systemic circulation leads to increased fasting glucose, insulin levels, and insulin resistance. Human studies have provided that good gut microbiota improves insulin sensitivity. So, a good diet and a good gut biota, maybe by supplementation, may give you a better insulin resistance profile. So, increase in gut mucosal permeability, LPS from gram negative bacteria enters systemic circulation, immune system is activated, low growth inflammation is induced, interferes with insulin receptor function, increasing insulin resistance, increasing ovarian androgen production also. So, all are detrimental for an ovulation. So, obesity and gut permeability, increased adipose tissue increases gut permeability, visceral fat deposit increase cytokines, that is again TNF alpha, increased cytokine reduced to leads to reduction in anti-inflammatory protein, that is adiponectin. So again, we have obesity, chronic inflammation leading to chronic inflammation, lifestyle, poor diet, and lack of exercise, again leading to obesity and chronic inflammation, polycystic ovarian disease, along with all its associations with insulin resistance, increased prostaglandin, increased cytokines, leads to chronic inflammation, and increased reactive oxygen species and abnormal mitochondria leads to poor oocyte quality and impaired ovulation. So the PCOS management, so the management of gut dysbiosis has a very important role. Alpha lactalbumin has been seen to improve. It enhances the epithelial barrier and it inhibits the pathogen adhesion. Production of antimicroorganism substances is seen. Competitive exclusion of pathogenic microorganisms. So it rebalances gut dysbiosis and achieves eubiosis. So the peak plasma concentrations of MI or MI with AL-LAC and MI alone, it has been seen with ALAC, the myoinositol concentration constantly rises. Is definitely better and it improves myoinositol absorption in vivo. PCOS is a state of MI deficiency in ovarian follicle. When there is the in the ovarian follicle fluid, the it is rich in myoinositol. The ratio of myoinositol to dechiroinositol is 100 is to 1. But in a PCOS, there is a 500-fold reduction in MI. That MI is reduced. The ratio of MI to DCI becomes 0.2 to 1, and thus we have a poor oocyte quality in a PCOS ovary. So PCOS with gut dysbiosis, the clinical, there is an effect of minoxidil plus alpha lactalbumin in minoxidil resistant PCOS women. This study has been taken and it says that it maximizes ovulation rate when 37 anovulatory women were given only minoxidil, 23 ovulated, that is 62% ovulated, and 38% when 14 there was no ovulation. Then minoxidil plus ALAC was added, and 12 out of these 14, 12 ovulated. So total of 35 patients ovulated when we were given a combination of minoxidil along with alpha lactalbumin. So thus we achieve a 95% success rate. So reduction in hyperandrogenemia is seen. This is very important, and we see at the end of the treatment, the percentage change, testosterone decreased by 35%, free testosterone decreased by 53%, dehydroepiandrosterone decreased by 47%, SHBG increased by 92%. So the recommendations of MI plus ALAC in PCOS, the recommendation is of the highest levels. These are the various recommendations, level 1, level 2, level 3. And so a comparative study and with Mayo and metformin both reduced HOMA-IR, and there was no statistical difference between the two groups. Effects of minoxidil and D-chironositol on hyperandrogenism and ovulation in women with PCOS. A systemic review says that both appear to be effective in improving ovulation and reducing hyperandrogenism in women with PCOS. MI is acting at the ovarian level, and D-chiro is acting at the peripheral level. So the dose has been optimized to 4 grams per day, and MI-DCI optimal ratio would be 40:1. The compliance, the taste and acceptability by the patient has to be there for her to be compliant in taking, and the formulation is micro-ionized granulation powder for better absorption and efficacy. So the clinical evidence and international consensus. Experts have consensus that clinical data demonstrates efficacy of MI-DCI in treatment of PCOD, and the dose is supposed to be 4 grams per day, and the ratio of MI-DCI 40:1. So the combination of MI and alpha lactalbumin was found to be effective in PCOS, and they are safe at therapeutic doses. US FDA included them in the list of recognized safe compounds. So the conclusion is PCOS is a complex disorder with a complex etiology. Insulin resistance and hyperandrogenemia play an important role in pathogenesis. Early diagnosis is key in addressing symptoms, improving quality of life, identifying fertility problems. Patient-centered approach with individualization of the management strategies. Lifestyle interventions improves quality of life. And high responders, we are freezing all, and which improves the clinical live birth rate, and embryo transfer is taken in the next cycle. Counseling regarding the long-term complications has always to be there. Minoxidil decrease insulin levels, glucose, and insulin and HOMA index. It also decreases hormonal parameters, LH-FSH ratio, and testosterone. It is able to induce normal menstrual cycle. It improves pregnancy rate compared to metformin. It's effective in ovarian stimulation protocols in PCOS. Minoxidil plus alpha lactalbumin effective in gut dysbiosis associated with chronic low-grade inflammation in PCOS. Thank you. Any questions would be welcome.
Yeah,
Hello, Dr. Anna.
Yeah.
How many cycles you recommend letrozole?
How many cycles of letrozole? I didn't get your question.
Letrozole for how many cycles you want to give?
Letrozole as such has no cycles, number of cycles have been recommended, as was this clomiphene that we have to give maximum of 6 cycles. But now the because it leads to only monofollicular development, which is as near to normal. So we can use a number of cycles depending on the age of the patient and her clinical presentation. We always have to review why the patient is not becoming pregnant in spite of ovulation. There could be other factors also. So that would be our reason of changing over.
How many patients have given step up this thing, dosage?
Step up dosage, I have tried in few patients and it has worked. When single dose wasn't working, I have definitely tried the step up dosage and it has worked for them.
The 5 milligram you give for 10 days or 7 days?
We can give 2.5 or 5 milligram for 10 days, or we can step up. We start with 2.5, next day 5, then third day 7. The step up protocol can also be used. And adding minoxidil plus alpha lactalbumin will definitely help in improving the quality of ovum.
Yeah.
Quality of ovum we are getting. So then the clinical live birth rate would increase.
Thank you very much, Dr. Vandana, for explaining such a complex topic. But I think we should give it to the pharmaceutical companies that we should be adding PCOS. Whenever you have a talk of PCOS, we should have it in a hyperandrogenism menorrhagia or cycle abnormalities, and then the pregnancy part. Because then it is too much of a this thing complication,
Yeah,
and then nothing gets into your head. At
No,
least
but then see, we are not talking about adolescents. We are talking for infertility over here.
yeah,
Basically, it was infertility. So
yes,
infertility, we have to look for all the three factors: hyperandrogenism, ovulation, and the live birth rate as well. So that has to be taken care of. In adolescents, we have a different view, and in the patients who have completed their families, we have a different view.
yes. But basically, when the patients will come, if you get a young patient, they will be coming with first, not with the infertility. Very few will come with infertility. Means a lot of them will come with menstrual irregularities. A lot of them will come with acne
Obesity,
problem also. Yes,
obesity. Yeah,
yes.
yeah, pubertal obesity we have to control.
Huh.
Yes.
Uh,
That is a totally different outlook. And over there would be, see, many of us are giving myonicitols to younger girls also. But then what is the focus of giving them myonicitols and for how long? They have to be managed in a different manner.
yeah.
Understood? Yeah. So they have to be managed differently.
Yes. Okay.
Any
Very
other?
well summarized, Dr. Vanna.
Thank you.
Very nice talk. Very well summarized.
Thank you. Thank you.
Okay. Thank you so much. Thank
Okay.
you so
Bye
much.
bye. So
Bye.
the organizers, are there any questions in the chat box?
No, ma'am. As for now, there is no questions from the chat box, ma'am.
So, okay.
Okay.
So
So, ma'am, if you're allows, then we can end this webinar for today.
yeah.
Yes.
Sure, ma'am. Thank you for being with us, ma'am. Thank you on behalf of
Okay
Sheila
then. Okay,
to
bye.
thank the
Bye-bye.
delegates also
Hello,
for
ma'am.
their patient listening. Thank you, ma'am.
Thank you. Thank you.
Bye. Nice.
Thank you, Vandana ma'am. Thank you very much for an
Okay.
excellent presentation.
Okay.
Thank you, ma'am.
Okay. हेलो कुछ नहीं वेबिनार